Hi, my name is Amelia Lyons. I'm the Clinical Supervisor Trainer in Aneurin Bevan University Health Board. Today I'm going to briefly talk about moral injury and moral distress and some of the steps that the Health Board is taking to address that in the health staff. Okay, so when we think about the definitions, there are a couple of ways. BMA, for example, has identified and made a distinction between moral distress and moral injury, and distress being a lighter form, as it were, than injury. So if we imagine the health professional, say on one occasion, not being able to follow through on something that they think is right because of institutional or organisational constraints. So the most obvious example of that would be refusing a patient a bed because there aren't enough beds. So although the professional may feel that the patient is ill enough, there are not enough beds and they're having to refuse the person treatment, and they're having to prioritise treatments in that process, maybe kick somebody else out of their bed who they think might be too early to leave hospital in order to admit somebody who's perhaps more acutely unwell, when actually the professional opinion would be that we should have more beds. Moral injury occurring when one or more of those instances occur, or something more acute and distressing is occurring. So an example of that could be in a wartime situation, or another example might have been in COVID, where you are refusing a relative to see a dying patient because of the rules of COVID, which is also very distressing for a member of staff. So what might other examples of moral distress and moral injury be? And every health professional, in my opinion, will have faced most likely many of these situations. So certainly in my past, I've seen members of staff refuse patients admission because of having no available beds or very few available beds, and they don't think the person is ill enough, and the thresholds for illness are then increased so that people get refused where previously they would have had treatment, and that can feel difficult to implement and apply when what's going on are cuts in spending, and it's the health professional is having to refuse people treatment where they wouldn't have chosen to do that. Inadequate staffing levels, perhaps managing on a ward with inadequate staffing levels and having to deal with the dangerous situations that might occur. So in mental health, that could be having a number of patients on the ward who kick off as such all at the same time. There not being enough staff to deal with that, and staff ending up getting assaulted on your watch. And that's not an uncommon situation in mental health. End-of-life care in general nursing, where perhaps different members of professional staff have different views about when somebody should be put on an end-of-life pathway, for example. So there are a number of issues, and I'm sure that any health staff watching this will think of further issues where they've had to face and had to apply rules that they haven't felt comfortable with. So moral injury can occur as a result of a lack of power or agency. For example, you're a very junior member of staff and you're not the person making the decision, but you may disagree with the decision. Or structural limitations, such as insufficient staff, but you have no control over that. Resources, training, or time. You'd like more time, for example, to address the treatment of the patient. You'd like more training. You feel you'd like more training. You'd feel you'd like more resources available for the patient. And you know exactly what those resources are, but they are not being provided. So the impact can affect our core values. And how do we then deal with that? Now, it can have profound feelings for us. It can leave us with feelings of guilt, shame, betrayal, anger, moral disorientation. All of these things in terms of concern for the patients and not being able to deliver, feeling constrained by a lack of resources, a lack of staffing, all sorts of things that will leave the individual themselves feeling that deep sense of guilt about the situation. And whilst it's not currently a mental health diagnosis in and of itself, it will lead to people feeling depressed, burnt out, even suicidal, and certainly accounts for a proportion of the health staff facing health problems facing the NHS today, including retention. Now, if we think about moral injury and moral distress, organisations and the system can't feel those feelings that the individual can. So what happens when resources are put under constraint and, people make cuts and so on, is that it's the individual who ends up feeling the strain of having to refuse somebody treatment, for example, having to put somebody in a corridor and treat somebody in a corridor. It's the individual who's feeling the guilt and the shame about rejecting somebody, being able to see their dying relative, not the organisation as a whole or the system as a whole, but somebody somewhere is carrying that guilt, that shame, that upset about it, and it's not the system as a whole. So it's me in the middle of that, the health professional, who's going to feel it. Now, we can therefore see that it does threaten retention in an already shrinking workforce. We can see that the issues need to be taken seriously, and both the BMA and the RCN recommend additional systemic work to be taken to address it more systematically and more fundamentally. So the BMA recommends that staff and that support is enable staff to talk privately in confidential spaces about how they feel, to develop support networks, and to develop a more open and sharing culture. And the RCN makes quite a few systemic recommendations around this area, saying that occupational health services need to be available to support the psychological and physical well-being of staff, that employers need to recognise the effects of this on staff and to act to get there, to prevent those issues and to get there sooner. That they should fund timely interventions and counselling and other forms of support for staff, that staff need to raise concerns, need to be able to self-refer to services, and that the professional voice must drive decisions. Now, in terms of that driving decisions around moral injury, it's difficult if there are not resources provided. So it's how then does the professional voice link up with the political and economic decisions about having to cut resources when people are very sick and then don't get their treatment does not get addressed. So this, it leaves us in a cleft stick in that sense, and there isn't an easy answer to that. Now, as a result of this, I put in a bid for charities funding, having attended myself some retreats on moral injury and some conferences, and felt that it would be timely to run some one-day retreats for a section of the health staff, including doctors, nurses, counsellors and psychologists, and staff who work behind the scenes in administration who may have been subject to distressing phone calls, for example, in COVID, and indeed at other times as well, not just during COVID. So what I developed was a retreat design, and I put that forward and made a proposal to the charities funding, and we got some money to run a few workshops for staff. So recognising that this isn't going to fully address anything like the problems, at least it's a start in terms of enabling staff to bring their issues to a private space and to talk about them and how they might have affected their professional identity, and giving them a chance to share their stories with each other, and then to signpost staff to places where they can perhaps dig a bit deeper and get some further support, for example, through staff wellbeing and other places that will address these issues individually. However, this is not a systemic addressing of the problem. It's only addressing it through individuals and through holding some staff development, and much more fundamental work needs to be done clearly. But this is a start.